This is a surgical technique video demonstrating arthroscopic repair of a complex radial meniscal tear. Radial meniscal tears transect the circumferential fibers, thus disrupting meniscal hoop strength. They have demonstrated rapid progression of arthritis due to loss of meniscal function. In this case, the patient presented as a 38-year-old male who sustained a knee injury while bowling. He reported buckling and instability with associated swelling. He had not had any prior treatment before presentation. Physical exam was notable for a palpable effusion along the medial joint line. His range of motion was 0 to 125 degrees. He had a positive McMurray test with medial joint line tenderness. He also demonstrated significant medial pain with terminal flexion. Diagnostic workup was initiated with radiographs. Standard knee radiographs showed maintenance of joint space without any significant narrowing, no gross malalignment, and no acute osseous abnormalities. MRI was thus obtained for further workup and demonstrated a complex radial tear of the posterior aspect of the medial meniscus with a horizontal tear of the posterior body. Given his symptomatic presentation and imaging evidence of the tear combined in the setting of his active lifestyle, he was indicated for arthroscopic repair of his meniscal tear. A combined horizontal mattress repair with transosseous augmentation was planned due to the biomechanical superiority of this construct as evidenced in the literature. For this technique, standard diagnostic arthroscopy is performed to confirm tear anatomy. A healing bony bed is then prepared in combination with a ranged curette and shaver to assist with vascular healing of the lesion. An aiming device is used to create a transosseous tibial tunnel. This is drilled under direct visualization to confirm the tunnel entrance is at the prepared bony bed. A cannula is then inserted to assist with suture management. A suture patcher is utilized to place a vertically oriented suture through the horizontal component of the posterior aspect of the meniscus. The other side of this suture is then placed through the anterior component of the radial tear in a horizontal mattress configuration. A nitinol wire is utilized as a suture passing device through the transosseous tunnel. This is brought out through the cannula along with the radial tear meniscus sutures. These are then shuttled through the transosseous tunnel and under direct visualization tied over a button on the tibial cortex for appropriate tension and reduction of the radial tear. Next, all inside horizontal mattress sutures are placed to assist with reduction and fixation. The initial suture is placed centrally in the meniscus at a distance of approximately 5 millimeters from the tear in both the anterior and posterior directions. Appropriate tension is confirmed under direct visualization utilizing a tensioning device. The suture is then cut flush with the meniscal surface. A second suture is then placed inferiorly at the same distance on the anterior and posterior aspects of the meniscal tear. Again, appropriate tension is confirmed under direct visualization. A third and final horizontal mattress suture is placed at the meniscocapsular junction at the same distance anteriorly and posteriorly. Final tensioning is confirmed under direct visualization. The final construct is evaluated with a probe to confirm appropriate reduction and fixation of the radial tear with appropriate tensioning. Most patients follow a standard post-operative meniscal repair protocol as shown here. Regarding outcomes, radial meniscal repairs have demonstrated healing in 93% of cases. But it has the added benefit of preserving meniscal function, leading to improved short-term outcomes. While long-term studies are pending, it is a challenging surgical dilemma, and reoperation rates are quoted up to 20%.